Let's look at the respiratory zone. So we talked about the conducting zone, its features, its location. Let's talk about the respiratory zone. And the function here is exchange. So exchange of gases between the air and the blood. Air sitting in the alveoli that's come all the way through the entire conducting zone, respiratory zone, and then blood sitting in the capillaries that are in close contact with the alveoli. In terms of the mechanism for this exchange, it's basically diffusion, which is why the cell layers here need to be very, very thin. So a very thin pulmonary capillary endothelial layer and a very thin alveoli epithelial layer. So two very thin layers that facilitate diffusion of these gases. And then some of the structures here at the respiratory zone are the respiratory bronchioles, and the reason that this is considered a part of the respiratory zone is because they're studded with alveoli. So although it's not the alveolar sacs, the respiratory bronchioles have a few alveoli that are studding their walls, which is why gas exchange actually begins here at the respiratory bronchioles. And then we have the alveolar ducts, the alveolar sacs, and the alveolar themselves, which are kind of like grapes on a branch. Notice again at this level, there's no smooth muscle, no cartilage, no goblet cells, no cilia, and a very, very thin diameter to allow for that exchange. Okay, so we have gases in the air are passing between these two surfaces. So here's our terminal bronchiole, respiratory bronchiole, which we have studded with alveoli, alveolar duct, which is going to continue all the way towards the alveolar sac. And then the alveolar sac are basically made of individual clusters of alveoli, right? And all of this zone is where we have gas exchange occurring. Much less of that happening at the bronchioles and then much more at the alveoli. Some of the features of the alveoli, first of all, they're very abundant, about 300 million of those in a single lung, which is about the size of a tennis court if you stretch them out. So very abundant, a lot of surface area here, very large surface area if you were to expand that to facilitate exchange. And this is the same thing that happens anywhere in the body where exchange needs to happen. In the lumen of the gastrointestinal tract, we have the villi, which are kind of very highly folded structures, but the surface area is what is important to allow for more exchange, more of that diffusion. And same thing here with the alveoli. Very abundant, intimately covered with lots of capillaries, this capillary network, and then that creates a lot of surface area to facilitate exchange. They're also very rich in blood supply, which means lots of capillaries. And then alveolar pores are in between each of these alveoli. And what these pores do is they help to just kind of equalize the pressure so that the alveolar sacs are functioning as a unit because they're communicating internally with these internal pores that make sure the pressure in one alveolus is the pressure in the neighbor and the pressure in the other and so forth. So the alveolar pores are really important to helping all of these many, many alveoli function together as a single unit. Another feature here are the cells that actually make up the alveolar walls, the type 1 alveolar cells. These are sometimes called pneumocytes. You may see that term in other areas, but type 1 cells or type 1 pneumocytes make up the actual surface area, the wall of an alveoli. And it's a very thin epithelial layer that comes in contact with the endothelium of the capillaries. We also find type 2 alveolar cells. These are going to secrete surfactant. These are usually on the inner surface of the alveoli. So the outer wall is epithelial cells, type 1 alveolar cells, and then inside we have type 2, which are taller, more rounded cells that actually make and secrete surfactant. We'll talk about surfactant's role, but very briefly here, surfactant is another structure that keeps the airway open, prevents these alveoli from collapsing along with the alveolar pores. And then alveolar macrophages, because we don't have any mucus at this level, because we don't have any goblet cells at this level, the macrophages here are what help to protect this part of the airway from any debris, pathogens, anything that could be invading this part of the tree, right? The respiratory tree. All right, so here are a few different views just showing you the blood supply to the lungs, the abundance of vasculature, the abundance of alveoli, and of pulmonary capillaries. So here's our pulmonary artery. Here is our trachea. Okay, here's our main bronchi, right and left. And then notice the abundant branching, very, very highly branched, lot of vascularization, lot of bronchioles as well. So there's abundance in both the capillary side and the bronchioles that will eventually give rise to the alveoli. You can see some of those alveoli interspersed here. And then together, this allows for a lot of interconnection for that exchange. Okay, we're going to keep moving on here with the alveoli. So the type 1 cells, just to point those out, here are a few of those. These form the wall of our alveolus. All right, whereas type 2 are more rounded and they project more internal. All right, so they're rounded. They're also found along the interstitial regions in between alveoli. You might find a few type 2. And then their role is making surfactant, whereas type 1 cells, their role is simply diffusion, right? Diffusion of gases. And then the other structure here, the macrophages. The alveolar macrophages are found within the alveolus, also found in the interstitium in between, and their role is to trap pathogens. One of the things that we'll see is in folks who live in areas with very poor air quality, or smokers, or folks in occupations with a lot of industrial debris, where they're exposed to a lot of industrial debris, they are going to have many more alveolar macrophages, which actually create these blackened areas in the lung. So when someone's lung goes from being bright pink and very fleshy colored to very dark and black and discolored, it's because of the abundance of these alveolar macrophages that are basically working overtime. They're absorbing a lot of debris, particles, toxins, environmental substances, and then they basically collect the debris, move out into the tissue, and then they start staining all of the lung tissue black because of their sort of excessive role with a lot of those toxins and exposures. So these alveolar macrophages are really important in keeping the alveolar clear, and then they can be, just working overtime if you are exposed to a lot of these pathogens and environmental particles. Let's talk about the respiratory membrane. The respiratory membrane is the epithelia down the level of the respiratory zone between the pulmonary capillaries out here and between the alveolus and the alveolar epithelium. So it's basically three structures coming together. It's the epithelial cell of the alveolus, which is made of the type 1 alveolar cell. It is the endothelial cell of the pulmonary capillary, which is basically our blood vessel wall, blood vessel cell wall. And then it is the fused basement membrane of both of those structures. So both of these structures are one cell layer thick, and they both have a very small basement membrane. And so here we have a fused basement membrane together creating one very small diffusion barrier for gases. So in terms of the structures that make the respiratory membrane, the alveolar epithelial cell, the pulmonary capillary endothelial cell, and then the fused basement membrane of both of those structures. And again, very, very thin, about 0.2 micrometers in terms of its diameter. So it's perfect for gas exchange. So this is just comparing the bronchiole, so looking at the diameter of a bronchiole versus the diameter of alveoli, right? So these are some of the alveoli, very abundant, a lot of surface area, and then very thin in terms of facilitating that exchange. Okay, I'm going to take a brief pause here for any questions. All right, so the thoracic cavity, as I mentioned earlier, it really helps to facilitate the movements of the lungs, which is what allows air to flow. We'll talk all about Boyle's law, Charles' law, the pressure dynamics of how air moves into the lungs and out. And the chest wall, really understanding the anatomy of the chest wall is super important in understanding that. So what are the structures here? First of all, the rib cage, which is made of the ribs themselves, the intercostal muscles, which we'll talk about. And we've also looked at these in the lab sessions. The costal cartilage. Costal cartilage allows for that movement. So it's not bone to bone, it's sort of cartilage helping to expand that connection. The sternum or the breastplate is another important structure there. The thoracic vertebra, which helps to articulate the ribs and actually make this space a cavity. And then the internal intercostals, external intercostals, diaphragm, as well as some of the accessory muscles we talked about, like sternocleidomastoid, scalenes, serratus anterior. Those can help, especially in times of respiratory distress. All right. Another important structure is the pleura. The pleura is a thin layer or a thin membrane that lines the lungs and the chest wall. It has two layers. One layer that's called a visceral layer, it's attached to the lungs, and that is continuous with the outer layer called a parietal layer, which is attached to the chest wall. So within those two layers is an intrapleural space, which is filled with a small amount of intrapleural fluid, also called serous fluid, about 50 milliliters of that. And the role of that fluid is to cushion the movement of those two layers as the lung and thoracic cavity move. So it just gives a little bit of lubrication, reduces the friction as those two layers slide past each other when the thoracic cavity expands, and then again when the thoracic cavity deflates, right, or gets smaller. Let's look at what those layers look like here. So here is our outer thoracic wall. Here are our ribs, 1 through 12. Here are the costal cartilages that attach from rib to sternum, again, allowing this space to be able to move. Then we have the lung internally, right? Left side, we only have two lobes here. And then we have a parietal layer to the pleura, which is attached to the thoracic wall, and then a visceral layer to the pleura, which is attached to the lung. And then in between those two layers, we have the intrapleural space, or the so-called pleural cavity. Okay, so the pleural cavity intimately covers the lungs, and then in between these two layers is that fluid that lubricates the movement as we have movement of the lungs and the chest wall. And I'll talk about why this space should never have air. Okay, if there's air in this space, that is dangerous. You're actually going to collapse your lung if you ever introduce air into this pleural space. So it should be not only a space with fluid, but a negative pressure space to allow the suction that keeps these two structures together. So if we were to introduce air into that pleural space, that intrapleural space, the chest wall would pull the parietal layer out, the lung would pull the visceral layer in, and then your lung would collapse. So very dangerous, that's called a pneumothorax. And so we want to avoid having anything other than fluid and negative pressure in between these two spaces. Okay, very